This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
Hello everyone and welcome to yet another episode of the 1 Million Live podcast by Laerdal. My name is Bjorn Egeland and I'm your host today. Today we have invited Dr. May Sissel Vadla to our studio. For those of you who do not yet know May Sissel Vadla, I can tell you that she is quite an extraordinary person. The most relevant now is that she's working on a PhD in health, technology and global health issues. And that is what she will tell us more about in just a moment. Now she is, as I mentioned, working on her PhD. So when she's not doing any field work, she will probably be sitting at a desk at Stavanger University or at home at Laerdal, where she is living at a dairy farm with 20,000 chickens and an impressive fruit garden, together with her husband and 2 children. And if that is not enough, on her spare time, she's also a novelist who has just published 2 novels so far. That was quite an impressive CV, May Sissel. So I guess my first question should be, what did your parents actually feed you when you were growing up?
Milk and chicken.
Yeah. Well, the reason why we invited you here today was that we were intrigued and wanted to learn more about your PhD project and the research that is the basis of that. I understand that your PhD project has included some rather interesting field work, which includes measures to reduce child mortality in connection with births at Laerdal Lutheran Hospital in Tanzania. Why this project and how did it all start?
I am a specialist in community medicine, and that means that I'm interested in prevention of diseases. So that's part of my specialization. So, and also we're interested in global health and how to decrease inequities in health worldwide. So for me, when I started thinking that I might want to take or do a PhD, I thought that global health would be the field that I was mostly interested in. And then I got in contact with Laerdal, which is now my main supervisor, and she's in charge of a very impressive project called Safer Births. And I was lucky to be invited into that project in 2019, I think. And then I got also to visit Laerdal and see all the great work they do there, the great research, the great clinical practice. And we started my PhD project, which then revolves around the simulation-based training in newborn resuscitation.
I see. Can you tell us a bit more about this maternity ward that you were working with at the Laerdal Lutheran Hospital? What was the size of the department? Or in other words, can you give us an indication of how busy it was?
Yes, the labor ward at Laerdal has 4,000 to 5,000 deliveries every year. And there is approximately 20 midwives working at the ward. So it's a very busy ward, and they have very many births per midwife.
So what kind of challenges do they have in this field in Tanzania in general, and at the Laerdal Hospital in particular, which you tried to help mitigate?
Every year, about 700,000 newborns die worldwide due to birth-related complications, mainly that they do not breathe properly at birth. And in Tanzania, their neonatal mortality rate, meaning newborns dying within the first month of life, is approximately 25 per 1,000 births. And this is, of course, then also the case at Haydam. So every intervention targeting the newborns that are experiencing difficulty breathing at birth are very welcome. And so that was the main challenge, I think, that were addressed by this intervention.
I understand that this is a challenge in many countries, not just in Africa. But in this case, the fact that you worked with this hospital in Haydam, that was because there was an opportunity there, so you went for it?
That was an opportunity, and they had also done a lot of simulation-based training previously. So they were accustomed to this way of educating their healthcare personnel. So what was new in this study was that they implemented a novel simulator with some new features, and also the implementation strategy that for the first year of the study, the midwives only trained self-regulatory, meaning that they could train when they wanted to, remember to train. And then after a year, the management appointed some local motivators, which simulates local champions in the literature. And they were then responsible to encourage the others at the ward to train, remind them, and also to make sure that the mannequin was always available and functioning, because that's also very crucial. If you're going to train, the simulator needs to work and be there. So those 4 midwives had that role of being local motivators for the last year of the study. That was the intervention.
Postgraduate, in this case, I understand, means the focus was on already certified midwives and health personnel, and not on students. Okay, so this is actually, as we often see in many other health institutions around the world, where health personnel are encouraged to keep themselves updated, acquire new skills, and learn new ones.
Yes, so this is the quality improvement in the clinical setting at the hospital for already graduated midwives.
So what were the key elements in this training? You just mentioned you used a system that gave automatic feedback, the simulator always being there, ready to be used when the personnel had a bit of extra time on their hands. But health personnel have always trained to an extent, perhaps normally with an instructor of some sort. What in your project stood out here and was, in your opinion, better and more efficient compared to a more traditional training?
2 things mainly, I think. Both the mannequin, the simulator that was new, that had a specific feature that I strongly believe in, and that was the automated feedback. So for a learner, like in this case a midwife, being able to do the training by yourself, you can do your mistakes without anyone watching, and you can get this specific feedback on what you did wrong and what to improve. And you get encouraged by the mannequin to try again. I think the combination of doing those individual skill trainings with that kind of feedback, and later also the team-based scenario trainings where you get that crucial training with your colleagues to rehearse the more complex tasks. But I think that feature of the automated feedback was important, and that was a motivation by itself, because we did see that the first year of the study, they still trained a lot. They trained nearly 700 times for 1 year, 20 midwives. So an average of about 2 trainings per midwife per month. So that was the one thing. And the second thing, I think, was the local motivators. Having someone in charge of the training saying yes and encouraging the others to train showed out to be extremely effective on training amount and then also on the training performance.
How easy was it to get people involved, to get them motivated and to use their spare time on this project?
It seems that the local motivators knew the tricks. And I think that was one of the success factors, that the management chose the right 4 midwives for this task. And going from 700 trainings in a year until 8,500 trainings the next year shows that, yes, it was possible to get the midwives to train, even though their schedule is very busy and the resources are limited.
So how often did each of the midwives actually train then? Do you have any data about that?
It was very impressive when we counted up the numbers. So on average, these approximately 20 midwives trained daily for the last year. So 26 trainings per month per midwife, which resembles daily. Yeah, if you take away the weekends, they trained daily.
Amazing. Wasn't there something I heard about an internal competition at this hospital?
Yes. What I think also was was a success was that the local motivators were given a lot of freedom on how to do this task, on encouraging the others. So they used their creativity and they arranged informal competitions at the ward. So they just split the ward in two, and then they competed against each other in how much they could train. And I truly believe in that, because I think we all get motivated by the team spirit, by a slight element of competition, and especially on a topic that's so serious. It's newborn deaths, it's resuscitation of a non-breathing newborn. And I think the element of something more lighthearted, the competitions was a very, very good trick from these local motivators.
You're listening to 1 Million Lives, a Laerdal podcast.
I see. I fully understand. In the core of this is naturally the question of newborn children's chance to live or die. I fully understand the need to distance themselves a bit from that, almost as a self-preservation technique. So yes, I can see how a friendly competition could absolutely work here. Coming back to the data collection, you collected quite an amount of data during this project. How was it collected, and what will happen to all of this valuable data now?
Every time the midwives trained using the mannequin, a lot of data from that training was stored on an iPad and then logged on a secure weblog. So we did have a lot of detailed information from every single training throughout the whole study period. We knew, of course, the learner ID, anonymized, and we learned for how long the training lasted, what mistakes they did, and also what patient case they chose, because this simulator provides 4 different patient cases to better resemble real life. So we did have a lot of information that we later could analyze, and especially then also look into the training performance. Did that increase, or did they just train without any results? But of course, they improved a lot their training skills.
It is still early days, and I understand you are still working on your PhD. But are you able to at least reveal some of the data that you collected, or some of the results? Any trends? Anything exciting?
No, we can reveal some results. I think the main result was actually the increase in training frequency, as we talked about, the 8,000 additional trainings from the first to the second year of the study. And also, we saw that the participation at the ward, like how many midwives actually participated in the training, also increased from 40 to 70%. And I think that's also a very important finding, because for the individual newborn being born without breathing, it doesn't help if that midwife didn't train and the colleague trained every day. So having a lot of the midwives participating in the training was a very important finding. And then at least we also saw that training performance increased from about 75% to 90% at the last year. Meaning that when you have conducted a whole training, as I said, you can get some feedback. Like, for example, remember to tilt the head so you get these open airways. Or remember to have the right amount of pressure, and so on. But if you do everything right, you get the feedback, well done. So we counted the frequency of those trainings, how many trainings received the feedback well done? And that increased from 75 to 92% between those two periods. So, and then the literature shows that this kind of training does translate into clinical practice. So we do hope that this will improve also the clinical management of the newborns.
Based on what we talked about earlier, I understand that your PhD will be focusing on global health issues. This particular project and the data you collected was this time from a small local hospital in Africa. But are there things we, in your opinion, can learn from this project, which is of value or can be transferred as a shared best practice to hospitals elsewhere in the world? What do you think?
Yeah, sure, I think, because we're pretty much the same, aren't we? So the factors motivating us, I don't think they differ so much from sub-Saharan Africa to Stavanger University Hospital. So the knowledge about the effect of using local motivators, for instance, and letting them have some freedom to be creative in how to organize this work, I think that's transferable to other settings. And I also think that it's very important to make sure that the learner, the healthcare worker, knows why they're supposed to train. What's the relevance of this training? And for this specific topic, I do think that the relevance seems more pressing in sub-Saharan Africa with a high number of newborns dying each year. And of course, that might lead to increased motivation compared to our setting. But it's also about knowing why we train and be able to communicate that and be able to remind ourselves about the goal for the training. And there are also things that these local motivators can be an intervention that could be relevant in other fields and in other settings as well.
You have accomplished quite a lot so far. But what happens now then? What's next?
The next step is very exciting, I think, because now we're going to look into the clinic. We're going to see for the same time period if something has changed in how these midwives handle the newborns that are not breathing. So I'm doing these analyses now, and I think it's going to be very exciting results. And then finally, we will also look into the newborn outcome to see if more babies survive. So I'm looking very much forward to seeing if all this training has been translated into the clinic.
Impressive.
What I also found very interesting when I looked at the results of this study was that it seems to be possible to train even though time is scarce. Even at a very busy ward, it is possible for midwives to find the time for this important training. And the literature states that limited time is one of the major barriers for training. And this study shows that it is possible, even in a setting with lack of healthcare personnel.
I assume that since you have gone through, university studies to become a doctor yourself, worked at hospital wards in praxis, worked together with nurses and others, and every time someone wanted to organize some training, it was always a question of, we have to leave the patient who's going to look after them when we are away, and there is always a lot of hoo-ha around this. And in the end, maybe just a few would come to this training session because the rest couldn't come. And by the end of the day, people are not trained to the level that they should be, not because they don't want to be, but because it's very impractical to actually get it done.
Yes, it's very easy to relate to as a healthcare personnel myself. And that's, for one, why I'm so impressed by these midwives that found this time. I'm so impressed by these local motivators that managed to really encourage the others for training. And also the way you organize this training, how important that is, that it's easy, accessible, it doesn't take many minutes. And even though I know and agree on the need for team-based scenario trainings as well, I know that, but you also need those individual skill trainings, and they might be easier to fit into a busy schedule if the simulator is situated near or at your workplace, at the ward.
So it's always there.
It's always there, and really it needs to function. We really need to make these simulators robust, and we need to have systems that make sure that someone is responsible to check that the mannequin is working. Because for me, I would say if I find a simulator not working twice, I will not go back for a third time, because you're busy and the patients need you, and then you cannot waste your time trying to train on something that does not work.
So you registered individuals that participated in these trainings. That means that you would also be able to pick out those who may need some additional training?
Yes, we could do that. When I looked at the data, it was anonymized. But for the management, if they really wanted to track each individual and give additional training, that would be possible with this system.
I see. So there is no sort of like a built-in approval system? Like, you go and you train, and then, if you succeed, you get some sort of like a diploma, PDF diploma or something like that?
Not for now, as far as I'm concerned. But what I know they've been doing with the simulator, and especially after this time period, in the next period that we're also going to study, where they improve their quality improvement program on this even further. And there they use the data from the clinic saying, okay, how are we doing now? Did we reduce time from birth until we start ventilation, which is very important in this aspect? And then they can see their own improvements and relate them to the training. And I think that's very motivating. So you can use this on a system level. And I think you can at least, for now, also get the numbers for the whole ward, saying that the ward has been training this much this month and not so much next month, and so on.
Fantastic. Well, thank you very much, Dr. May Sissel Vadla, for this very interesting story. I was really motivated myself, I must say. I hope the listeners have been motivated as well, and we will include a link to your paper at the laerdal.com/podcast page. And Dr. May Sissel Vadla, I must say I'm also looking forward to hear more about how the project continues to develop when you go into the second phase of this project. Thank you very much for taking some time off your busy day and spend some time with us here at this podcast.
Thank you so much, and thank you for having me.
You're welcome. All right. Goodbye to you all.
Bye.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.